Welcome everyone to my 12-month progress report, and let me introduce you to some of the research work that I have been doing since September in the topic of clinicopathological evaluation of cutaneous lupus. My name is Bokor. I'm a medical doctor and a full-time PhD student at the Department of Dermatology at Semmelweis University. My vision is to improve the quality of life of patients who are suffering from cutaneous lupus. And in order to achieve this, my mission is to find more efficient therapeutical options for this disease. Currently, I have two ongoing projects, both in the topic of cutaneous lupus, but I'm using different methodologies. My first topic is the investigation of the efficacy and safety of novel therapeutic options in cutaneous lupus, and I'm doing a systematic review and meta-analysis. But first, let me share a few pieces of information about this disease. Cutaneous lupus erythematosus is an autoimmune skin disease. There are more than 300,000 new patients every year worldwide who suffer from inflamed, scaling, or scarring lesions, or they might have scarring alopecia. Due to these symptoms, they have a substantial decrease in their quality of life. Currently, the gold standard therapies for cutaneous lupus are either topical or systemic glucocorticoids or antimalarials. But as you might already know, glucocorticoids might have serious side effects, and unfortunately, the response rate to antimalarials is only approximately 50%. Recently, novel therapies have emerged, such as biologics, like a new promising one, anifrolumab, and small molecules, such as JAK inhibitors. However, there's only limited evidence available on their efficacy and safety in this disease. So our aim is to find the most effective and safest novel therapy in cutaneous lupus. Our clinical question is quite similar: what is the safest and most effective novel treatment in this disease? To answer this, we are using the PICO framework, where our population is patients with cutaneous lupus, and we compare biologics and small molecules to placebo or no comparator at all. And our outcomes are efficacy and adverse events. One of our efficacy measures is the CLASI 50 score. The CLASI score is a specific score in cutaneous lupus which measures the activity and the damage of the disease on a scale from 0 to 70. And the CLASI 50 means the number of patients who have reached at least a 50% reduction in their CLASI activity score. And our hypothesis is that this new biologic, anifrolumab, is the most effective and safest novel therapy in the treatment of cutaneous lupus. We have conducted our systematic search in 3 main databases, and here's the flowchart of our selection, where we ended up with 58 eligible full texts. So let me introduce you to the structure of my meta-analysis, because it consists of 2 parts. The first part is a network meta-analysis of the randomized controlled trials, and the second one is a standard meta-analysis of the observational studies. And in both parts, we are investigating 3 outcomes. The first one is the number of patients who have reached the CLASI 50 score after treatment. Second is the odds ratio of any adverse event, and the third one is the odds ratio of serious adverse events. Here you can see my network plots from the network meta-analysis part, where you can observe the direct comparisons between these novel therapies and placebo in terms of efficacy and safety. So first, I would like to introduce you my results regarding the number of patients who have reached at least a 50% reduction in their CLASI activity score after treatment. On the upper left-hand side, you can see my net forest plot, where all novel therapies in cutaneous lupus are compared to placebo. So you can observe a clear ranking between them. And based on our results, deucravacitinib was the most effective treatment of all, since more than 8 times as many patients have reached at least a 50% reduction in their disease activity when treated with deucravacitinib compared to those who have received a placebo. Moreover, anifrolumab and litifilimab were also significantly more effective than placebo in treating cutaneous lupus. On the upper right-hand side, you can see my p-score plot, which shows how confident we are in our results regarding this comparison. And down below in the league table, I would like to highlight some of the indirect comparisons that we have made during the analysis, where deucravacitinib and litifilimab were significantly more effective than ustekinumab and baricitinib, and anifrolumab was effective than ustekinumab in treating cutaneous lupus. And here is the safety profile. The results are regarding the safety profile of these treatments. In the net forest plot, all therapies are compared to placebo again. And there were no significant differences between these therapies and placebo in terms of the odds ratio of any adverse events. And there were also no significant differences among these novel therapies in their safety profile in the indirect comparison, so we can conclude that these are safe treatments. The third outcome was the serious adverse events. Here are also all treatments are compared to placebo, and there were no significant differences regarding the odds ratio of serious adverse events between these novel therapies and placebo, except for one case, which was baricitinib. I would like to highlight some of the strengths and limitations of my study. This study is a comprehensive meta-analysis of novel therapies in cutaneous lupus. It has a network meta-analysis part as well, and we work with high patient numbers. However, there's high heterogeneity of the CLASI outcome, and we could only make few direct comparisons. In conclusion, deucravacitinib is the most effective and well-tolerated novel treatment in cutaneous lupus. Our implication for practice would be the suggestion of the early use of deucravacitinib in clinical practice, and we would like to highlight the necessity of incorporating deucravacitinib in the newest guidelines for cutaneous lupus. Our implications for research is that we need an evaluation of the efficacy of anifrolumab and deucravacitinib, anifrolumab versus deucravacitinib across various organ domains in systemic lupus. And there's a unified efficacy measure is also needed in cutaneous lupus. Here's the progress of my first project. Currently, I'm writing the manuscript. And I would like to jump to my second topic, which is the epidemiological evaluation of patients with cutaneous lupus. And this is a retrospective cohort study. So the incidence of this disease is around 4/100,000. However, there's still few available data on the specific epidemiology of these different subgroups of cutaneous lupus. So there are several open questions about the difference in gender distributions in these subgroups, the prevalence of certain comorbidities, such as autoimmune or malignant ones, clinical laboratory differences, the prevalence of systematization, or the epidemiology of rare subtypes. Unfortunately, there's only one previous register available, which was published in 2013. It collected data from 4 years. So our aim is to collect data from the last 10 years at the Department of Dermatology at Semmelweis University, which is one of the biggest centers in Hungary for autoimmune skin diseases. And our aim is to analyze the prevalence of rare subtypes, the male-female ratio in these subtypes, comorbidities, smoking, or we would like to also investigate the first, second, and third line treatment options in Hungary. So all in all, our aim is to provide an up-to-date epidemiological data in cutaneous lupus. In summary, I have these 2 ongoing projects, both in the topic of cutaneous lupus. The first one is focusing on the therapy of this disease, and the second one on the epidemiology. And I would like to thank you for your attention with the works of Banksy, which is if you get tired, learn to rest and not to quit. Thank you very much.
Hello. My congratulations in your progress. Really interesting. I would like to ask about your first project. Does the severity of the patients with cutaneous lupus erythematosus have the same influence on the treatment? I mean, these different type of the drugs, they study the same level of the severity of all patients or no? And is it potentially influence the results? How you think?
Sorry, can you repeat again in the what of the patients?
No, I mean you discovered the effect of different drugs. Yes, in the treatment. Do all these patients were the same level of the severity of this disease?
Oh, okay. So unfortunately, cutaneous lupus is quite heterogeneous. Yeah, so they were also in the different subtypes of these diseases. So these drugs have a different impact on the different subtypes of cutaneous lupus. So that's also a bit of limitation. And also some of them had only cutaneous lupus, but some of them had systemic lupus with cutaneous involvement as well. So that's also a complicating factor, since they also have a systemic disease. So it's quite a heterogeneous group of patients, unfortunately. Yeah.
Okay, so potentially it's also influenced the results somehow?
Yes. Yes.
Okay. Thank you very much.
Thank you.
Congratulations for your wonderful presentation. I have a question regarding your first product. What were the most common adverse events?
Thank you very much. So most common adverse events were infections, usually nasopharyngitis, upper gastrointestinal tract infections. In the case of JAK inhibitors, there's evidence that they had more thromboembolic events as well. So usually these two types of safety problems that we have with these diseases, but mostly infections.
Thank you.
You said in the end that unfortunately there's a register as well. You could argue it's good that there is a register as well.
It's a good, yeah.
And that register, it was done where exactly?
It's from Sweden. It's from Sweden, but the data was collected from all over Europe.
Oh, I see. So it's kind of a heterogeneous population then.
Yes.
So in a way you can argue that yours will be better because it's more homogeneous.
Yeah. Well, yes. So our population won't be that heterogeneous with a higher patient number, but we won't cover.
So you will have a higher number than them.
We hope.
Perfect. And the other one is that, could you go back to your first slide? Can we ask for that?
Yes, of course.
In the network meta-analysis, I was not sure. Yeah, perfect.
Here?
I was not sure how to interpret the top left, because I was not sure that in network meta you can produce these kind of figures. So, for example, you concluded, I think, that deucravacitinib was the best here.
Yes.
Based on how many studies? Like how can I tell?
So for each, so these are pooled results from different studies. So for example, deucravacitinib, there was only one study on deucravacitinib, but there were 3 on litifilimab or 3 on anifrolumab, and we pulled all those results from all these studies, and this is how we generated this.
But then in the end, you can conclude that it's the best from all of them.
Yes.
So all you can conclude is that it's better than those 2 that you highlighted, right?
Well, we can conclude based on this that if we compare them to each other indirectly, that it's better, yes.
But not compared to everything. Is it better than litifilimab?
Sorry?
Is it better than the last 2? Is it better?
Yes. Which one? Deucravacitinib?
Yes.
Yes. So this is a ranking also.
Is that study significant?
We don't have comparison statisticals. We just only say that based on the odds ratio we have here,
Perfect.
it's better, but it's we couldn't compare it statistically. Yeah.
I want to ask you that you mentioned that the implication for practice would be the early use of deucravacitinib. If just, for example, if maybe I would have CLE, what would be your suggestion to use deucra, or maybe to use just the anti-malarials or something else?
Yes, thank you for your question. So currently, unfortunately, deucravacitinib is not in either of the guidelines for cutaneous lupus, but usually biologics are second or third line treatments and always add-on therapies to the basic treatments. I would say that based on the CLASI score and the activity and the damage of the disease, in first aid, I would also or always choose antimalarials, maybe also a bit of corticosteroids, either topical or systemic, but only in a low dose if the disease is absolutely active. And then we could move on to the second line treatments, and they usually are methotrexate or azathioprine or sometimes mycophenolate. And usually after the failure of that therapy, they give these biologics to the patients as an add-on.
Last quick question. Why was your hypothesis that anifrolumab is the best?
Yes. So based on the pathomechanism and based on the effect of anifrolumab. So anifrolumab is a type 1 interferon receptor blocker, and that's one of the main pathomechanism way in cutaneous lupus. So we hypothesized that since it blocks that, it would be the most effective based on the pathological findings in cutaneous lupus, but it wasn't right.